Hi, good evening, everyone. Welcome to the webinar for aid to support on wrong site surgery. My name is Dr. Logan. I'm the clinical lead for dermatology, and Jonathan is with us as well. Is the plastic surgery lead. So thanks for joining, giving up your time. This evening we'll spend between 20-30 minutes just to go through presentation, and then we'll have a few minutes at the end for general discussion. The reason we're doing this webinar on this topic is because over the last few years we've had quite a few cases of wrong site surgery, and the trust report them back to us, so we run them through the governance process, and we look at root cause analysis and what learning outcomes we can take. So what I will do is just share my screen now so we can go through presentation. Okay, so avoiding wrong site surgery. What we'll do is go through a few examples to start with, and then we'll look at procedural aspects of booking patients for surgery in order to help avoid wrong site surgery when the patient has their procedure, and then techniques at the time of surgery to ensure that the correct site is identified. So wrong site surgery is classed as a never event, and it is an invasive procedure performed on either the wrong patient or at the wrong site. And we haven't had any procedures performed on the wrong patient, but we have had multiple wrong site surgeries, and they're nearly always a lesion is removed within a few centimeters of the lesion that was intended to be removed. The incident is detected at any time after the start of the procedure, and the start is defined when the patient's anatomy begins to be permanently altered. So we had a case down in Dorchester where the surgeon had started putting the anaesthetic in order to remove a lesion, and one of the nursing staff alerted the clinician that that was the wrong lesion. So it wasn't designated as a never event wrong site surgery because the patient there was no scar formed because it was just an injection. Wrong site surgery makes up about nearly a half of all never events reported from 2021 to 2022. And we'll just work through some examples from our practice and then discuss some of the reasons why wrong site surgery might have occurred. This case was a patient that had been referred for excision of a lesion on the left upper back and shave excision of a lesion on the right lower back, and this is part of the booking form. And we can see lesions marked on the back. Here is the photograph taken from clinic at the time of booking, where a left upper back lesion is dotted, ringed, and marked number 1, and a right lower back lesion is dotted, ringed, marked number 2. When the patient attended for surgery, see these indelible ink markings had been washed off, and the clinician assessed the area and excised the lesion on the left upper back, but they excised this lesion just superior and medial to the lesion that was intended to be excised. When we were reviewing the case, one of the points that was raised was that on the booking form, there were 2 circles marked on the left upper back, one of which was superior and medial to the other, and this one had a number 1 in it. And this slightly different approach that was marked for the right lower back. So this was potentially contributing to the wrong site surgery in this case. Case number 2 is a patient that was referred for a punch biopsy of an atypical nevus on the left temple, which was a 4mm lesion, and it was marked on the body map as being just above the eyebrow and designated on the left temple. Here is the booking clinic photographs, and we can see a lesion is measured with the label, and it's marked with ink, and it's present above the level of the eyebrow, and it's at the anterior hairline and quite a few centimeters above the top superior rim of the ear. This is the WHO checklist from the surgery, and we note that the site was deemed to have been carefully confirmed, but a mirror was not used. And after the patient had left the department, he got into his car and he looked in the rearview mirror, and he realized that the lesion that had been biopsied wasn't the lesion that the clinician had intended to be biopsied. So he came back into the department, he alerted the nurse staff and the doctor, and then the doctor performed a second procedure. And here is a photograph taken about a week after surgery. The patient's cut his hair now, and we can see the red ring marks the first lesion that was biopsied, and the green mark was the second lesion that was biopsied, and this correlates to the lesion that was actually referred for biopsy. So it was deemed a wrong site surgery. Case number 3 is a patient that's been referred for excision of a lesion on the back, and it was clinically a suspected BCC, and it was marked on the booking form as being 6 by 4 millimeters. And on the patient's back we can see signs of sun damage, lots of lentigines, multiple scars. We have oblique scars here, just lateral to the arrow, and another oblique scar below the arrow. And if you extend the line along the arrow's pointing direction, there's a larger lesion here. And this larger lesion is the lesion that was excised by the surgeon. And when the histology came back as a seborrheic keratosis, the local clinicians thought that was unusual. And when they reviewed the photos at the time of the operation, they realized that the lesion had been biopsied, and actually the tip of the arrow was pointing to where the BCC or the clinical BCC was deemed to be. So those are 3 separate cases, all of which include lesions that are not directly visible to the patient, and I think this is something to bear in mind as being a risk factor for wrong site surgery when the patient can't directly point to the lesion. In the first 2 cases, it was the patient that identified the wrong site had been operated on, and in this case it was the trust clinicians on assessment of the histology. So just to go over the pitfalls again, the first patient, he had multiple lesions on the back, and the booking form had markings with 2 areas in close proximity on the left upper back. And how could wrong site surgery have been avoided? The patient, you could have taken a photograph of the patient's back and marked the lesion, and then they could have looked at the photograph themselves and agreed, yes, that's the correct lesion. You can review the patient standing in the same orientation as the clinical images, and you can orientate the lesion for surgery with the photographs, which were preoperative photographs, were quite clear. The temple lesion, it was a lesion in a hair-bearing area, and wrong site surgery could have been avoided if the patient had been given a mirror, or the doctor had used the patient to confirm with the patient which lesion is to be biopsied, and again correlating with photographs. And what we decided about the lesion that was removed, the seborrheic keratosis removed from the back, was that there is a risk in using arrows, in that an arrow could point to multiple lesions. So we suggest that when you're completing a booking form, that you use the circles around the lesions rather than arrows. And in this case, the lesion that was excised was quite a bit larger and clinically didn't match the description of a BCC. So there were other features that could have been correlated to avoid wrong site surgery. Here is just an example of typical elderly patient with sun damage. These patients that have over 100 lesions, sometimes on the back, and they might be referred for excision of 2 or 3 lesions, or multiple different types of procedure on the same day. So just to be aware that this is a risk factor for wrong site surgery, and high quality images required. And another option you can use is designating the level with respect to the spinal column and the vertebra. And then, for example, if it's at the T10 level to the left side, you can measure from the spinal column how many centimeters lateral to the column is the lesion. Another pitfalls, and these next couple are just that I've found just from the last week or so, and I'm sure all the clinicians on the call will be familiar with these examples. Patients do misidentify the lesion that is for surgery, and if they've had a gap of maybe a few months between the booking and the time they attend for surgery, it's quite likely they might point to a different lesion. So you have to be a little bit suspicious when the patient says, this is where the lesion is. This patient pointed to an area about a centimetre, 2 centimetres away from the area that actually had been biopsied. She'd had a shave biopsy, which was a BCC, incompletely removed, and I've seen this patient with a view to excising the residual tumour, and the green marking is where the actual biopsy was taken from. So the second point is just, if you are going to shave or curette small lesions and it's a superficial biopsy, they can heal very quickly, even within 3 or 4 weeks, and it can be very difficult to find the biopsy site. So I suggest high quality images taken of all small lesions that are going to be biopsied in this manner. Another pitfall is when the clinicians use the wrong anatomical terms for the location of the lesion, or as in this case, a patient I saw just the other day, the clinician who'd seen the patient in clinic described the lesion as located on the left nasojugal fold in the diagnosis section, but in the body of the text they described it as being in on the nasolabial fold, and when the patient had been referred for biopsy, the biopsying clinician who did a punch biopsy described it as being on the left nasolabial fold in the clinic biopsy letter, and the histology form and the histology report also said it was on the nasolabial fold. So it's just an example of how, if you use the wrong terms, when the patients come for follow-up surgeries, the clinician will struggle because the wrong term has been used. So the fix is, you can use an anatomy mapping chart or reference chart, and just need to be accurate about the terms used for locations of lesions when they're being biopsied. So ensuring the correct site, these are a couple of processes. We'll split it into part 1 at the time of booking and then part 2 at the time of surgery. So at the time of booking, obviously we're visiting lots of trusts and they all have their own booking procedures that we need to follow. But the key things that we need to ensure are completed is the anatomical site with accurate description, and the laterality of the lesion, the size in millimetres, unless it's very large, in which case it's acceptable to use centimetres. If it's a small lesion, or if it's, for example, a lesion in the hair-bearing scalp, then you might need to use triangulation, which is requiring 2 measurements from fixed anatomical structures, and ideally mapped out on a diagram. Diagnosis needs to be documented and body map chart marked and the photograph marked as described with a ring around the lesion, and legible handwriting. Describing lesions, preferably write out in full left or right rather than abbreviation, and remember to use describing position anterior, posterior, medial, lateral as necessary. A lot of patients that I'm seeing say referred in and it just says the biopsy was done on the nose, and they can be small lesions, and obviously the nose is quite a large structure with lots of different subunits, so better descriptions are laterality, specific point in or a subunit like the supratip. Anatomy Mapper, it's a free resource. You can just log on through the browser and basically you choose this section of the body where the biopsy you want to take from. You just move the cursor over the area and it will give you an anatomical term which you can use, and then obviously this can be objectively replicated by other clinicians. In terms of taking photographs, as an example, if we draw a circle around the lesion, we can mark it either with a letter or a number, depending on whichever trust, whatever their convention is. And obviously, a lot of our patients are having multiple biopsies and multiple lesions, so there might be 4, 5, 6 lesions that need biopsying. So just be very clear about the documentation. And ideally, in the photograph, we have the patient details with the date of the photo, because I'm sure you will have come across instances of patients having photographs uploaded to their record of other patients. Certainly down in Dorchester, we've had a few cases where the wrong patient's photos have been in the record there. So if there is patient details in the photo, then obviously we avoid errors in that regard. Taking photographs, if it is in a hair-bearing area, I suggest trimming the hair down, and that probably also goes for if you're asked to clinically examine a lesion in a hair-bearing area. We've had one case in Dorchester where the lesion was a melanoma on the scalp. The clinician had described it as or had diagnosed a basal cell carcinoma, and the patient had been referred on a routine pathway rather than 2E weight pathway. So it definitely will restrict your diagnostic accuracy if you're trying to diagnose or visualize lesions through a lot of hair. So just explain to the patient it's going to be short term, trim the hair down, take the photograph, mark the lesion with a ring, and make sure that there is a wide view of the photo showing orientating fixed anatomical structures, so the lesion can be identified with reference to fixed points. And then a close-up view can also be helpful. Here's an example of triangulation. So you might choose a structure such as the lateral canthus, and if you have a lesion on the left temple, you might say, okay, it's 18 millimeters above the lateral canthus, and then it's 15 millimeters posterior. So at the time of surgery, obviously we're all doing biopsy lists. The first thing is to carefully read the clinic letter and the booking form and establish where the lesion is, what the diagnosis is and how big it is. And then we need to make sure that we've looked at all available photographs. And I suggest having the patient with you when you're looking at the photographs as well, so you can both agree where the sites are. If it's not directly visible area, then give the patient a mirror and get them to check it. If it's the back, then you can photograph the back and show them the photograph, and correlate that the lesion measures similar to the booking form, but appreciate that there may have been some growth or change in the lesion over time. If it's a small lesion, as described before, just make sure that a photograph is taken in case it's hard for a clinician to find at follow-up if the lesion needs to be completely excised. Make sure that you use your support in the theatre, either nursing colleagues or healthcare assistants, to jointly review images and to jointly assess the patients, so there's collective agreement that the sites intended to operate on are the sites that the clinician has referred for surgery. And if you remember, on the WHO checklist, there is a timeout point for this discussion to occur before the first incision. And the other main point is that we will support clinicians if they have any doubts. They can't be completely sure based on the evidence available and the patient's description that they've got the correct site to operate. Then just cancel the procedure, and then we can always rebook it. And for quality improvement, it's important that if there are any errors or inadequacies in the booking processes, that we should feed these back to the local trust or even to our own clinicians to ensure that we can avoid patients having either wrong site surgery or just having to have their procedures cancelled. So in terms of what we need in the operating room is a camera, a marker pen with rulers, and a handheld mirror, and obviously our checklist, and we'll be using the trust checklist. Here's a useful mantra as they use in carpentry: is measure twice and cut once. So just take your time, be conscientious, don't have too many distractions when you're going through the process of ensuring where the lesion is that you're going to be biopsying. So here's the summary of the two parts of the process at the time of booking and then at the time of surgery. And here are the main points. So we all have a duty to ensure that whoever's operating on the patient has all the evidence that they need to confirm the site correctly. And we're going to follow a robust process, and we'll all have slightly different processes, and every trust will have slightly different processes that we need to follow. Some will use a WHO checklist and some will use their own checklists. But of course, yeah, if in doubt, postpone the operation. And just remember that ultimately the responsibility for surgery remains with the surgeon. And here are some references with the anatomy mapper. Okay, so I think those are the main points. We did have more wrong site surgeries, but with respect to time, I didn't include them all. I think it might be helpful for us to have, if anyone has any questions or if they want to share any of their own experiences with wrong site surgery or ideas about how we can mitigate the risks, then I think that would be useful. Let me stop sharing. Jonathan, do you have any points or any tips, things you found useful in your practice? Or
think of how I do it. It's always the list of items you've given is very helpful and is entirely accurate. And I think we all get in our own way of working process. And of course, I think one thing we should all remember is we're all going into different trusts here, and it's a bit like when you start your first day in a new rotation or whatever as a trainee. It's you're not in your comfort zone, and you almost just have to be acutely aware of that. I think fortunately we tend to work with staff who we may be familiar with, but that does make it more difficult. So I mean, I think we probably all have our ways that we lean on certain aspects more than others. I mean, triangulation is mine. You don't get too many patients who've had the triangulation measured, but it's sort of reference points to often other pigmented lesions, the formation of them, and that's what I lean on the most, I would say. But I think if we think back to the ones we've looked at, Ian, I mean, the photographs have often been there, and it's just a case of taking that time just to, because I mean, the skin surgery usually takes no time compared to the rest of it, the documentation, the process. It's just taking that time to look at the picture. I agree the patient can often be unreliable. So in your own mind, before they come in, which one is it and how am I identifying that? They come in, you repeat that, and for me, it's more often than not triangulation. But I think we all have our ways of working, but that's what I lean on the most.
yeah,
And I think, as you said, we're very keen to hear ways that people work or mitigate things. And it's interesting you mentioned about anatomy mapper, because that has been brought in at Southampton. And it's interesting from an anatomical perspective. That isn't necessarily mirrored in surgical practice, because you look at some of the nomenclature and think, oh, I probably wouldn't have described it as that. So if you're going to go with a mapper or a mapping tool, everyone has to be on board with this is what we're using, because for instance, I think it's the flank on that. It's very specific, and we tend to say anything which we deem not to be the midline, the flank. It tends to be quite broadly used, so that's just something to be aware of, really.
I suppose the other point is that not every trust is routinely using preoperative photographs.
Yeah, and I think that's an interesting one, because it might be that when we think of Southampton is where there has been more, and their photographs, in my mind, are good. Are they easy to access might be a different issue, and that's something they're working through. But perhaps we've just identified it more, because at other trusts it's certainly less frequent, and the photographs of a poorer quality.
Yeah.
Sure.
The other point that can be helpful is that even elderly patients now, I mean, nearly everyone has a smartphone, and with a high quality camera, with multiple megapixels. So that is a backup option, is that when you're taking the trust photos, but the patient, you can also take photographs on the patient's phone, so that they have some ownership as well, and there's like a joint effort between you and the patient to ensure that the correct site is operated on. Because like demonstrated in those two cases, it was the patient that immediately they knew it was the wrong site. soon as they left the room. So
yeah, I think obviously that's all the clinical aspects of how to avoid it. I think it's probably worth a mention that 18-week support dropping into so many different trusts, there has to be a due process as well when there's any uncertainty. And probably for the plastic surgeons, it's if you are unsure, then the process is cancel the patient, as Ian said. But at that point of cancellation, we do obviously get a dermatologist in, which is nearly always present. Obviously, there are some plastic surgeons who do loads of diagnostics. That's obviously less common, but have a dermatologist look for diagnostic purposes. The nurse in charge has to be informed because you're one step from really a cancellation, and then cancel and bring back. And I guess it is different to how we may work in our own trusts, but when you are really a visitor in other trusts, you have to have this sort of layers of decision making, really, so that you have follow due process. So that's just obviously an awareness of how I think we all know that it works if there's any uncertainty or there's going to be a cancellation.
Okay, great.